And now we'll go ahead with Dr. Thenarasan, please.
Yeah,
Yeah, you're
yeah, my screen is visible.
no.
Not yet.
Thenarasan.
Yes.
Yes.
Good evening, everyone. And I'd like to thank Dr. Chitra ma'am and AOC for giving me this wonderful opportunity. So I'll be debating about why anti-VEGF should be the first choice in pseudophakic DME. So for that, we should understand the pathogenesis of diabetic macular edema. So the best agent of choice should act against both the mechanism. It should also have anti-VEGF effect and it also have anti-inflammatory effect. So as Dr. Preetham has mentioned that steroids do have both the effects. Similarly, anti-VEGF agents also has both anti-VEGF and anti-inflammatory properties. So we have a wide range of anti-VEGF agents. So ranibizumab and aflibercept. Ranibizumab being a antibody fragment has a smaller size, has deeper penetration and faster clearance, both from the vitreous and as well as from the systemic circulation. So it primarily indicates the less systemic side effects compared to the larger molecule bevacizumab. And again, aflibercept has a wide range of action against all VEGF and placental growth factors. So this study shows that anti-VEGF inhibits the leukocyte transmigration and leukocyte re-entry into the cells of retinal circulation, especially in the angiogenic retina. So it indicates that in addition to the anti-VEGF property, so these agents also have anti-inflammatory properties. So coming to the DRCR net and RESTORE study, so they have indicated that especially in the protocol I, so if you start early treatment with ranibizumab, it provides sustained visual acuity gain over a period of time. So it has been studied in the RESTORE study as well. So if you see the protocol, as I saw, Sarah's mentioned clearly, but if you see the subgroup of pseudophakic and phakic patients, pseudophakic patients have an equal compared to the anti-VEGF and steroid. But if we see, compare the side effects, the systemic and local adverse effect, that is the IOP rise, the ranibizumab group has less side effects. So I would prefer going anti-VEGF as a first choice compared to steroid therapy. The recent protocol U, they have two groups. One is the monotherapy anti-VEGF and second is a combination therapy anti-VEGF along with a dexamethasone implant. At the end of 6 months, if you see, there is no any statistical significance between the two groups in compared to the final visual acuity. But if you see, the IOP rise is more with the combination group. So why would you prefer a combination group if the visual acuity, there is no any difference? So you always prefer anti-VEGF as a first choice. So in nutshell, if you see this tabular column, so all these studies at the time of a final assessment at the end of 3 years, the final visual acuity is more or less same, or in the case of VEGF, it is slightly more compared to the implant, dexamethasone implant. So again, if you compare the side effect profile, so I would always prefer anti-VEGF as a first choice. In the MEET study, the dexamethasone implant, the increased IOP was the second most adverse effect, and it is seen in almost 30% of cases. So if you see, after intravitreal steroids, the IOP rise, the risk factor increases after a single injection. But whereas if you compare with the anti-VEGF injection, the risk factor increases if it is more than 12 injections. And again, the percentage is very less compared to the steroid group. So the increased IOP is a common complication of intravitreal corticosteroid regardless of method of delivery. So again, this adds burden to the patient for treatment for managing glaucoma, and again the patient needs additional follow-up and for the frequent monitoring of IOP. But Sarah's mentioned that if you give an intravitreal steroid implant, you can follow up the patient once in 2 or 3 months, but it's not so. If you want to monitor the IOP, if you wanted to monitor the close monitoring of IOP, you need the patient for frequent follow-ups. So again, there is an anterior chamber migration of intravitreal implants and IVTA. So this can again damage corneal endothelium, and this risk factor is more in cases of pseudophakia and if there is absence of lens capsule. And there is some entity called sterile endophthalmitis. It is a non-infectious. It is mainly due to the toxins and preservatives in the syringes, and risk factor incidence is more in intravitreal triamcinolone compared to the anti-VEGF agents. So again, if a steroid responder is there, definitely you cannot choose a steroid. The anti-VEGF should be the first choice. Again, if there is a tachyphylaxis to the anti-VEGF, again you can change to a different drug, and again anti-VEGF should be the choice. So in conclusion, so the benefit and risk ratio of treatment should be considered in patients with diabetic macular edema, and evidence-based medicine is very important. So my first choice should be anti-VEGF as a monotherapy in cases of diabetic macular edema. So if the patient is not responding and if there is a chronic edema and is refractory to therapy of anti-VEGF, then you can go in for a combination therapy of anti-VEGF along with steroids. Thank you.
Thank you very much, Dr. Thenarasan. Wonderful talk. Preetham and Thenarasan both were very good.